Good evening, friends, to the audience and to other postgraduates and the friends, those who are watching us in the various corners of the country. Today I am going to take you to the interpretation of common laboratory investigations in our daily practice. I think one thing I would like to bring to your notice before going for the discussion, that before you submit any investigations, we should have the clinical diagnosis. And our working of planning of this investigation should be based on our clinical diagnosis. We know the investigations are neither the shortcut nor the final answer for the diagnosis. I think every clinician should be very clear. We know that advancement in the technology and availability of the modern facility for the investigations has brought the revolution. That's very certain. But still it is an extra help. It is not the substitute for the clinical diagnosis. Everybody should be very clear. Once you decide to go for the investigations, in what way? Sequentially? I think once the patient is stable, we can go sequentially because it will be the cost effective. But once we are working in the intensive care unit, we know that we don't have the time to wait. And if we wait, probably we may face serious problems. In that situation, we can take the liberty to go for the battery of the investigations. But if the patient is stable, I think I can go step by step. At the same time, every clinician should know the possible errors with even the lab investigations. And if you are not aware, probably our interpretation may be totally wrong. And then whole our base of the management may not be appropriate. So in short, first draw the final conclusion with a reference to the correlation of the clinical diagnosis, not just from the readings of the laboratory investigations. At the same time, we'll have to use our knowledge, our wisdom. We'll have to go for the correlation of all the aspects before drawing the conclusion for the diagnosis. And I think this art every clinician should learn. This is very important, just going for the investigations, looking at the reading and deciding the line of the treatment is not appropriate. Before probably we go for the interpretation, we should consider certain points. Which are they? The collection of the sample at the appropriate time. We'll have to see that malarial parasites peripheral smear is prepared before starting the antimalarials. If somebody has already given, probably I may get the negative smear. We know that the lumbar puncture should be performed before starting the antibiotics. Otherwise it is going to change the picture. And then probably will not be that clear. We know that a serum Vidal should be taken after 7 days of the fever when you are suspecting the enteric fever. The blood collected for the Vidal on the 5th day and we say that the Vidal is negative. Vidal is negative. That creates the biggest problem. So it is very important at appropriate time. Second, proper technique of collection of the sample is also equally important. That we know that if properly not collected the blood, even it may get hemolyzed. And hemolyzed sample will give the lots of the errors. Just if I am pumping, that pumping can cause the hemolysis. Once I have collected the blood in the syringe, and if I pass in the container through the needle, that force will cause the hemolysis. May not be noticed. And then hyperkalemia. Or maybe probably something else. So I think that is every small point. Today I have decided that I will bring to your notice which I have learnt while working for 30 years. And I am sure that it makes a difference. Collection of urine for the urine culture is very important. I tell my postgraduate that you tell how the sample is to be collected, how you are going to explain to the mother. And that's very important. Otherwise, if sample is not collected appropriately, whatever the colony count and everything comes may be wrong. We know that Mantoux test should be given by intradermal route. Somebody has given by subcutaneous, and everybody says men to test is positive. And I'm sure that in daily practice, if you try to recollect in your daily rounds, these are very common. And therefore probably we should do it appropriately, otherwise our interpretation is going to be wrong. I think every postgraduate should know that for this particular test, in which container the blood should be collected. It is my routine that in the orientation, every postgraduate should know. And I'm sure that daily it happens so. We know that from EDTA sample we can go for the CBC, even the blood group, ESR, fetal hemoglobin, Coombs test, direct Coombs test, but not the indirect. But once you want to go for the indirect Coombs test, it should be collected in the plain, because from the serum we can do. So we know that when you want any test from the serum, it has to be collected in the plain. And we know that the amount of blood will require more. Fluoride bulb, we know that if it is not collected for the sugar, we know that the sugar level is going to be low. And erroneously we will say that there is hypoglycemia. We know that nowadays we estimate the blood sugar from the plain bulb. And if it is done after the few hours, the sugar level is going to be low. And there is very common mistake. Heparin, we know that if you want to go for the ammonia estimation, in a case of hepatic encephalopathy, if you have not collected the blood in the heparin, nobody can give us the ammonia level. Many times my students are fighting with the pathologist that why you are not giving the ammonia, but how he can? We know that from the citrate blood, all the coagulation tests, if you want to perform, the citrate sample is very important. And you, at the same time, if you are knowing that for the blood culture, very appropriate that media bottle has to be there. So I think the container is also important. If it is not done properly, your interpretation may not be right. Storage of the sample, we know that suppose the patient has come at midnight, and probably immediately it may not be possible for us to set the sample for the examination. How we can collect it, how we can store it. You know that the blood culture the sample for the blood culture should never be kept in the refrigerator. But this mistake is commonly seen. The blood culture sample has to be there in the room temperature. Ideally it should be incubated at 37 degrees centigrade. And I think for us 37 degrees centigrade is around the year. So there is no problem. Except few months in Ahmedabad particularly that there may be cold. But I think Bombay is not facing the problem. We know that the urine collection, at the midnight patient has come with a complicated UTI if you are suspecting clinically. And once you collected the urine culture sample, and immediately it may not be possible to approach the microbiologist. We'll have to store it. And that urine culture sample should be kept in the refrigerator at the 4 degrees centigrade, 4 to 8 degrees centigrade. It is said that suppose if it is not possible even for some long time, maximum you can keep it for 18 hours, not beyond that. All these are the scientific facts from the studies they have done, and I think that strictly we should follow. In short, which sample should be kept in the refrigerator and which one not in the refrigerator is very important. If I tell you in the nutshell, please remember, any sterile sample like CSF, blood or body fluids should not be kept in the refrigerator. Sterile sample should be kept in the room temperature. And any contaminated sample is likely, like urine, that should be kept in the refrigerator. Because here we want that particularly the contaminated, if it is organism is there, it should not get these circumstances to grow. At the same time, if the sterile sample, if it contains the organisms, let it grow so that I can get this culture positive. So this is very important dictum, and remember, sterile samples should be kept at the room temperature. And if likely that they are contaminated, contamination is possible, then keep the samples in the refrigerator. And I'm sure that these mistakes are not uncommon in your daily practice. Timing is also very important. CSF we have done 2 hours back. The servant goes, I will say, while talking and finishing other work. Our friend's pathology may be busy with some other activity, and the cell count you are getting after 3-4 hours. And then we say that not correlating with our clinical picture or with the protein, how it is. CSF cell count should be done within 30 minutes. Insist your friend, I think train your friend pathologist, that chemistry you may give it later on. but the cell count in the CSF should be performed within 30 minutes. And I'm sure that once you start it, it will make the difference in our interpretation. We know that Mantoux test should be read after 72 hours. Ideal Mantoux test should be read by the physician, clinician, pediatrician, and not the pathologist. Because we know every aspect of the clinical. And with that reference you can interpret. Not just reading of 10 millimeter, 15 millimeter is not important. At the same time, we should know in the history that before coming to you or before collection of the samples for the specific examination, which drugs the patient has received. Suppose already patient has received some antimalarials. Even in spite of your diagnosis of malaria, you may not get it. At the same time, you know that the antibiotics in UTI or bacterial meningitis, enteric fever, changing the whole clinical picture, changing the all, I will say, interpretation of the investigations. And that we'll have to learn that how best we can do. Probably that I'm going to discuss later on. So friends, what I want to convey to you, then very important for every clinician, that interpretation of the investigation should be with reference to the clinical background. Some mother says that when occasionally I'm getting the phone call from the medical mother, that sir, my child is having some cough and fever and the pediatrician has asked for the Mantoux test and that is about 12 to 15 millimeters. Should I start the AKT? Nobody can answer and nobody should answer. So I think that's very important that just looking at the figures of some investigations, one should not draw the conclusion. Serum viral may be positive, but the patient is playing, no fever. I think why should I consider? That may be even with the exposure in the past. Unnecessary, why we should consider it. So the point is very important that we should go for it. We know that HRP2 test, which we are doing for the malarial parasites, particularly for the falciparum, may remain positive for a few weeks even after the successful treatment. But suppose the patient comes back to me with a fever after a few weeks, if I go for the HRP2, it's going to be positive. I will say again falciparum. Maybe the wrong interpretation. That fever may be due to something else. Maybe viral, maybe enteric, probably maybe something else. Maybe even the falciparum also. So the point is probably I should know that these tests may remain the positive for a few weeks, even in spite of the successful treatment. And therefore your interpretation will not be wrong. All of us know that in our country, due to the endemicity and anamnestic reasons, viral may be positive for you or for me without fever. And that aspect should be known properly. And that fever which is going on with mild titer should not be wrongly interpreted as the enteric fever. Many of the people say that the patient is not responding to the enteric fever. But if the enteric fever is not there, what you have diagnosed on the basis of the enteric some titer is due to something else. And here the probably patient is suffering from some other condition. As a clinician probably we'll have to use this wisdom if probably we have the clear knowledge and the concepts regarding the interpretation of the investigations. We should know the sensitivity and specificity of each test so that we can consider that how much importance I can give to the positive test. We know that positive predictive value of the CRP for neural sepsis is less than 50%. And on just CRP positive, we jump for the antibiotics. I think it's not the correct answer. Okay, at the same time, other points are helping me to say that it likely sepsis, probably it permits me to start the antibiotics. But just a CRP positive, and I think not uncommon in your daily practice. On the contrary, I will bring the point to your notice that 2 times I have done the CRP negative, probably it excludes the neural sepsis. The reason is the negative predictive value of the CRP is more than 90%, 98%. That means if the test is negative probably, it increases my confidence to say that it is not neural sepsis. So for me probably, rather than positive CRP, negative CRP is more important. And positive CRP, then I will look at the other points. And if it is helping me to say that it is a really sepsis, I may consider it. So this point is very important that every test we should know the sensitivity and the specificity. At the same time, we know that blood culture which had shown the Salmonella typhi, probably there is no doubt for considering the enteric. At the same time, malarial parasites, rather than even the antigen test, if the smear is positive, that's pakka malaria, no doubt. So we should know that which test, how much I can rely upon, and that as a clinician, we should be aware of it. Let me take to you some of the common things which we are doing daily, but probably we are not paying much attention that how we should interpret. On the contrary, we have asked for the CBC. Patient meets me on the way, showing the CBC. Just I look at some figures, I say normal. But I think if you go in the details, many things abnormals are there. Let us take one by one. We know the CBC is a simple, probably not that expensive, and our routine. Sometimes probably without indication we are asking for the CBC. It is also not right, but okay. But the reasons are often given by cursory, as I said, very superficial. We are in hurry because you know every time what we say, we are so busy. I think that excuse should never be allowed. You are busy does not mean you are permitted to do anything. Still we'll have to do it very appropriately. And it provides lots of information. It is performed correctly, as I said, from starting from the collection to the storage and everything. And interpreted appropriately with reference to the clinical background. I remind you very frequently, every investigation should be interpreted with the clinical background of the patient. That's very important. I think now everything we are doing by the cell counter. Then we should be as a clinician aware that what is the cell counter, how it functions, and what are the likely even the mistakes or the errors due to this machine. What happens, we know that it generates an electrical pulse when the blood cell is passes through a small aperture which is surrounded by the electrodes. That's I will say, technique of functioning of this machine. And each electrical pulse represents an individual cell. So each cell is counted by the pulse, by this machine. And the pulse even, it indicates height also. So it counts. It gives a cell volume also. And therefore, you know, histogram which you are getting, that we'll have to learn that how we can interpret it. It registers the total cell count. It estimates the average cell volume also. And you know, that is very, very important. That provides lots of information. And we know that by this method, RBC count, MCV, RDW, everything we are getting. Even we are getting the granulocyte count. It provides with the absolute values also. Hemoglobin, hematocrit is performed. MCH and MCSC, they are actually calculated from the figures. And that's the thing that how you are getting the whole CBC report. On these ways now, what are the possible mistakes that I will show you, and as a clinician we should be aware of it. What are the limitations of this machine? Their standardization of the machine is necessary, and that we'll have to ask the pathologist that when last standardization of your machine was performed. He may not be knowing. Very common mistake. And I think that's why variations in your samples you are getting. Many times we say that today the very high count we are getting in many patients. Sometimes even the low count. Probably that may be the problem with the machine, standardization. And whenever it happens in my medical college, I always ask the pathologist, I give the ring, sir, probably it requires the standardization of your machine. And he says with just smile, probably yes. And it happens so. Platelet count and automated even differential count. This is very important. Whenever you get the platelets count by the machine, by the cell counter, that may be wrong. That may be erroneously show the thrombocytopenia. I think in the season of the dengue fever it happens so. Very frequently we are asking for this platelets count. I am learning from my friends, good hematologist, Dr. Nitin Shah and Dr. Bharat Agarwal also, Mamta Manglani madam even. They say that whenever it happens so, always ask if this platelets count from the peripheral smear by the prick method. And then you will get the real platelets count. What happens particularly in the EDTA bulb even, microthrombus, which will consume the platelets, or even by the cell count also it is possible. And you know, this is the pseudothrombocytopenia, maybe the short note in MD examination. It happens, as I told you, by the EDTA. Even sometimes some of the areas we'll have to learn, which I am learning from my friends hematologists, that in our own country, from the Bengal, Assam, northeastern part, somehow they have these macroplatelets. Normally they have the larger size of the platelets, and therefore count point of view it may show the thrombocytopenia. I remember 2 or 3 patients where we were getting the constantly thrombocytopenia in one patient, and the patient was from Bihar. Then I came to know that without any problem you may get it, that we should be aware of it. And I think these points are very important for our proper interpretation. All of you know that these are the components of the CBC, how best we can utilize it. Let us see. Another thing, as a pediatrician we should be aware that normal values of individual parameters for age are variable. Open the book and check it. What I say abnormal for the older child may be normal for the neonate. And that if I am not aware, I will wrongly say that something is wrong. Even we know that initially the blood count may be high in the newborn, which I consider leukocytosis for the older child. I think everything is true for all the parameters. And therefore always I tell my students that open the book for that age and verify whenever it is borderline or the doubt. And as a pediatrician we should be aware. You know, for adults probably he has to keep only 2 things, adult and pediatrics. For pediatrician we know the different age groups, adolescents, young children, even the infants, newborns also full-term and preterm. They have the different parameters. So this is also very important to decrease the mistakes in our interpretation. Whenever we get the anemia, as a clinician, probably if you try to check it, it's an acute one with fever and deal with the pigmented polymorphs. Probably as a tropical pediatrician, not difficult for me to say, probably it is malaria. And once you are used to, it's a sudden. Previously suppose somebody has done hemoglobin, that was 10. After 3 days patient is brought to me and it is 7 or 6. The drop of hemoglobin 3-4 grams in only 2-3 days in a case of fever. And some good pathology says that there is a pigmented polymorphs. I think in the absence of even the parasites, confidently I can say that probably it's malaria. And I think this skill as a tropical pediatrician will have to develop it. I'm learning from Dr. Amrekar, I think you must have attending him, that we have to be the master clinician in this country. And probably if we, nobody can compact us. Probably we should not, these are, as I told you, the investigations are the extra help to me. I don't make the diagnosis from the investigations. Probably it increases my some confidence. That's very important, which every clinician should know. We know that suddenly hemolysis, even long-term, sudden hemolysis may be malaria. But if the hemolysis of the long time, maybe even due to torch, maybe even the recurrent malaria, maybe even viral infection, thalassemia, sickle, so many things. Even the anemia can be due to chronic infection also. If I don't have the answer for this anemia, which is of long time, maybe due to the UTI, maybe due to even bacterial endocarditis. And this is the thing which I want to bring to your notice. A child of more than 5 years who is suffering from pneumonia, and that patient is not responding to routine our antibiotics. And when I am noting that there is a drop of hemoglobin, anemia, always give the thought for the mycoplasma. And now mycoplasma is not uncommon. If I quote my own experience, probably frequently we do come across. Frequent plate, even the platforms have discussed it. That as a clinician now, we should be aware of it. It's not uncommon. Even the pneumonia, when goes for the multiple system involvement, go for the cold agglutinin test, and probably these other tests, you will get it, and that's a mycoplasma. So I think with the pneumonia, when unusual picture or something probably related to the anemia or hemolytic process or multiple system involvement or even the Coombs viscosity, probably that will help you. And that's the only point that the line of treatment is different. We know that hemolytic anemia patient is, which I am knowing and coming to me regularly, suddenly goes for the drop of hemoglobin with a fever for a few days. Always keep in mind, and only selectively anemia, count and platelets are not affected. That means only erythroid series is affected. You know, these are the things that how it, for differentiation it helps. Probably that can be with the parvo B19. And any patient with hemolytic anemia, when goes for this other picture, is a life-threatening. And if you don't probably interpret it properly, it may create the problem. All of us know that HLH, that familial is different thing. But secondary HLH is not uncommon in your daily practice. Which probably we have diagnosed dengue or enteric or something. Patient was probably doing well, suddenly starts with a fever, even the hepatosplenomegaly, lymphadenopathy, drop of hemoglobin, drop of platelets, or even the count. Always keep in mind that this patient is going for the HLH, and we know it's a life-threatening condition. And secondary HLH is quite rewarding. Probably familial, we may have the limitations, but secondary due to these infections and not uncommon. Frequently I have discussed even due to miliary tuberculosis, brucellosis, which I have come across the HLH. So I think this is a very important interpretation appropriate with your clinical background. With the anemia, anything always, don't see only isolated hemoglobin. Probably anemia for anemia, hemoglobin, hematocrit, peripheral smear, and reticulocytosis. We'll have to see all the points together, and that will draw the clinical picture that what is the likely cause for the anemia in this patient. If I see the anemia with reticulocytosis, probably I am confident bone marrow is working very well, because the overwhelming response of the bone marrow with reference to anemia. But at the same time, reticount is low. And reticount also don't go for this just plain figure reticount count. Go for corrected reticount. Or go for the reticount product index, that calculation. Because you know reticount is one the figure also depending upon the mass of RBC. And that with the mass of RBC it will be variable. That again will give me the incorrect information. But with the reference to the correction to the RBC mass if I go, and therefore we compare with the PISA-V, that will give you the correct information. And I think that requires, I'm sure that with these exercises, any damn cause of anemia, you can diagnose. And that's, I will say, clinician's role. So always look at this, particularly the reticulocyte count. We know that even the macrocytic hypochromic anemia, very common in your daily practice. Maybe most common iron deficiency. But at the same time, thalassemia trait, not responding to your iron, and not uncommon. At the same time, lead poisoning may not be that common, but definitely we do come across. If you keep in mind, definitely we get it. Even sideroblastic anemia, anemia of chronic disease even. Friends, I would like to draw attention with this macrocytic hypochromic anemia, that once you have diagnosed iron deficiency, but serum ferritin level is normal or elevated, it should never be iron deficiency. Cause is something else. Maybe thalassemia, maybe something else, maybe even chronic infection also. Thalassemia should be considered in patients with chronic macrocytosis with normal serum ferritin levels, particularly when you go in the details of the history that from which caste the patient is coming. And very specifically if you are able to locate that from these communities, probably that will help you to draw the thalassemia. And thalassemia classical picture can be diagnosed by any person. But these type of situations are there, that becomes difficult for the clinician unless he goes for the details of interpretation and proper working of this particular clinical situation. HB electrophoresis. Keep in mind that alpha thalassemia trait, we are going to miss it with the normal HB electrophoresis. Probably may not be common in the western part of the country. Where I am working at, we don't get it. But I am learning from my friends, Dr. Kundu, and from the other friends from the eastern part, that they have the alpha thalassemia. And they are facing the problem. So I think, and now we know that it has not remained as this eastern part and western part. Now the not only whole country, but the whole world has become very small. Everybody is, I will say, traveling and even the migrating everywhere. So probably that thing has broken down. What we used to say the Kala Azar is not common in Gujarat, but Kala Azar is seen in Gujarat because people are coming from that area due to some work or due to some other reason. Equally true from the Bombay. On the contrary, Bombay there will be the more issues because multiple people are migrating from the various parts of the country. And I think as a clinician, all these aspects we should be aware of it. We know that the HbA2 level even, once we are finding the difficulty, we go for the HbA2 level. I would like to remind you, even megaloblastic anemia, it is going to be raised. Not only thalassemia trait or minor. So whenever you are finding the difficult, look at this MCV. MCV may be above 100, or go for the peripheral smear, which might be showing even the macrocytosis. So whenever you are having this problem, look at these things before drawing the, because once you say thalassemia, that becomes for the lifetime, which may not be true. So before probably labeling, consider all these aspects, and probably occasionally we do come across. WBC. Very common daily and still lots of the issues. On the contrary, please don't give much importance to the leukocytosis. It is having very wide variation. Somebody maybe when the 12,000, 13,000 may be normal. And we know that 4,000 also may be normal. So probably we cannot give the much importance from this unless some other points are there. Second thing, once you decide for the leukocytosis, don't jump for the antibiotics. Count is very high, fever is there. I think that indicates to me some inflammatory process. And that inflammation can be due to the various reasons. Okay, commonly due to infection. But not necessary. It is a non-specific. It may be infected, it may be non-infected. It may be the process of having some collagen disorder. It may be even due to some malignancy. So probably we should not jump. Even in infection also, initially viral also may give the leukocytosis. Maybe even the neutrophil reaction on first or second day. So don't make the conclusion that the count is 20,000, 80% polymorphs, and therefore leukocytosis, polymorph nuclear reaction, therefore bacterial infection and antibiotics. I think this our equation should not be there. This is a very important interpretation which I want to bring to your notice. Once the count is high even, don't jump for even the leukemia. Maybe it may be the case of leukemia reaction, not uncommon with the pertussis and tuberculosis. And particularly tuberculosis, when it happens at the hepatomegaly, splenomegaly, lymphadenopathy, and count is more than 50%. We jump for this leukemia. Frequently I have come across, probably our friends hematologists must be coming across more. But once you go for the peripheral smear examination, there are no blast cells, all the mature cells. So I think that leukemia reaction should not be interpreted wrongly for this leukemia. And just I will say the parents, their malignancy is likely, I run away, but they will not be able to sleep. On the contrary, they will become the restless, going from person to person. And many times if not appropriate person, series of the complications start. So I think as a clinician, we should be aware of all these issues before interpretation of the investigations. I have given the one slide for this only one sentence, purposefully, that every leukocytosis does not mean bacterial infection, not necessarily we should go for the antibiotics. Maybe, but the only thing I have to confirm it. Only leukocytosis should not be the parameter for defining that is a bacterial infection. We know already talked the leukemia reaction, neutrophilia due to reason, eosinophilia. When we say the SIP to the left, I think somebody asked in my MD examination, when we say the SIP to the left, more than 5% immature neutrophils in the smear, not only just, I will say, mature cells, is also very important. Leukopenia, neutropenia. I think when randomly my postgraduates give me this interpretation in the round, I always say leukopenia. I say, what's the definition of leukopenia? That I will, by definition, very important to go. Neutropenia, but go for the absolute neutrophil count. And I think that is very important that we should keep in mind these figures. We know the leukopenia due to various reasons. Maybe simple viruses. Most common cause for the leukopenia is the viruses. All of you know. Maybe even sometimes overwhelming sepsis also. And that is probably a more dangerous situation that all of us should keep in mind. This is very important probably marker which will help us. Lymphocytosis maybe, the 60,000 count, but lymphocyte 80% and all are mature. Maybe the pertussis. Abstinent by virus, not uncommon. Even tuberculosis we do get it. Atypical I think atypical and this abnormal, they are different, not the same. On the contrary, atypical indicates more of the cytoplasma. And that can be with even the Epstein-Barr. On the contrary, that is the characteristic of the Epstein-Barr. Lymphopenia even may be there in some of the conditions like malnutrition. Whenever you get the monocytes and that to increasing monocytes in some chronic condition, probably it's a good sign that patient is recovering from this basic condition. Suppose in a case of miliary, if I later on get the monocytosis, it's a good sign. Eosinophilia you know, but eosinopenia point of view I would like to bring one of the points, and that is the antric. Suppose if I am getting the patient of fever more than 4 or 5 days without the focus, I don't have the answer, probably now less chances of viral, antric remains one of the possibilities, viral at present I cannot perform, probably I should go for collection of the blood for the CBC and blood culture. And CBC shows that in spite of the very high grade fever, count is within normal limits or low, which one showing not the neutrophil count, but the pathologists say that hardly any eosinophil is there. And if the CRP is raised, where count is low or normal, and acute phase reactant is raised, probably in these circumstances before I conclude, as a clinician I may say that the antric is more likely. And I think that is a very appropriate interpretation of every aspect of the investigation with a reference to the clinical picture of the patient. So I think this is the thing which you should keep in mind. At the same time, somebody has given the steroids, check it, eosinophils will not be seen. And whenever you are suspecting any adrenal problem, look at the eosinophils. Hardly seen. So I think these are the conditions which will help you to see from the peripheral smear and probably from which you can derive some appropriate condition. Neutrophilia, all of you knows, probably I may not go into much detail. The only point which I want to bring to your notice that neutrophilia even in a acute viral infection initially may be there. We should not be misinterpreting it as a bacterial infection. But neutropenia is very important. Less than 2,000 absolute count. Maybe probably very bad bacterial infection possible, or maybe any viral infection. And I think that's according to the situation we have to keep in mind. I think if you conclude viral, I may not worry much. But really with the bacterial infection and patient is going for neutropenia, definitely we are more concerned. Occasionally when the patient is on chemotherapy even, any malignant condition, even neutropenia is not uncommon. The point is why I want to bring to your notice, if the patient has fever and neutropenia, condition is febrile neutropenia. And febrile neutropenia is a different entity. It requires immediate attention. It requires specific antibiotics, which I said I don't start the antibiotics. Here I will jump for the antibiotics. And that too very specific. Once I label the febrile neutropenia, I will go for piperacillin tazobactam, which I don't even routinely use. Or I will go for cephalosporin sulbactam. Or even I will go for ceftazidime or something. In short, these are the antibiotics which commonly we don't use. But once I label it as a febrile neutropenia, what is the cause for the febrile neutropenia? I will have to go, because if I don't go for that, if I don't interpret it properly, it is a major killer. So I think it's a clinician, very important point for us. I think not only just the count, look at the morphological changes. And I think all the changes you are knowing, just I skip to save the time. I want to bring you to the platelets count. Always go for the platelets count first. And as I said, keep in mind the pseudothrombocytopenia. If from EDTA bulb, due to the macrothrombi, your platelets count may be wrong. In that situation, confirmed by the peripheral smear by the prick method, still it is low, okay, then it is thrombocytopenia. That can be the viral infection, very common with us, including dengue fever. Very important point which I want to bring to your notice. Any patient who is having the isolated thrombocytopenia, hemoglobin is normal, count is normal, repeatedly when the platelets somebody has done and low, even may not be fever, but having some symptoms, keep in mind the HIV. HIV is known to present as an isolated thrombocytopenia. Keep in mind, I come across several patients. If I just give the example, few months back, very young child, 5-6 months old child, which was hospitalized for pneumonia at some pediatric nursing home. Little bit improved, discharged, again came back to our college. And that patient, already I also said that it is infection, maybe viral bronchiolitis or bacterial, we'll have to go for workup. Meanwhile, CBC, my resident told that there is a thrombocytopenia. I said that thrombocytopenia may be due to this problem of VDTA, you go for the platelets count. He said, sir, there was a thrombocytopenia with the previous pediatrician also. I said that 2 people have noted independently thrombocytopenia. Now I cannot ignore it. Looking at the circumstances, the child was from some labor class. Mother was actually staying from Sikkim or so, and that gentleman was working over here. Looking at even the circumstances of the family, I went for the HIV. Mother was positive, father was positive, child was positive. What I want to bring to your notice, isolated thrombocytopenia, HIV is known. If I don't have the answer, rule out even the HIV. Bacterial infections, we know that even the endocarditis many times the fever and thrombocytopenia. Count is quite high, but the low platelets, leptospirosis syndrome, enterocephalus, malaria even. Even the P. vivax with the thrombocytopenia is very well-known entity. But P. vivax with thrombocytopenia, don't consider it as a complicated malaria. Because by definition complicated malaria, treatment is different. We'll have to go for artemisinin combination or something. But if I say P. vivax without complication, not severe malaria, then we'll have to go for chloroquine. So here, even if with the thrombocytopenia, only isolated thrombocytopenia, otherwise patient is well, and P. vivax, treat it with the chloroquine. Don't go for this, even the treatment of severe malaria in the form of the artemisinin or artemisinin or something like that. So in every point why I am going to details that it makes difference in a decision of the management. And in long term it works very well. Thrombocytosis, very high count platelets, more than 5 lakhs. It may be reactive in any case of infection. But if the thrombocytosis is there, in a case of fever of unknown origin which is going on since long, and you are gradually increasing, initially 5 lakhs, 7 lakhs, 8 lakhs, even 10 lakhs platelets, in a case of fever, and not having even any other much information. Leukocytosis is also that, little bit drop of hemoglobin, maybe collagen disorder, maybe Kawasaki even. On the contrary, if having some skin lesions, I will keep in mind the Kawasaki. And these are the things that how it gives a clues for the consideration. But the fever which is going on since long, hepatomegaly, lymphadenopathy or something, but the platelets are low, probably it indicates maybe some malignancy rather than collagen disorder. So I think this is the thing that how best we can correlate and interpret, and we can draw and therefore our next investigation will be very conclusive rather than inconclusive. If I am thinking for the collagen disorder, I will go for the profile of this. If I am suspecting malignancy, I may go for either the lymph node biopsy or the bone marrow. And the next moment probably I will get the answer. This is the thing that how the correlation will help you. Even we know that the thrombocytosis may be in a patient of asplenia. Asplenia. When you remove the spleen, the platelets are not removed from the circulation and they increase in the number. Even in a case of, if I remind you, probably celiac disease, I am not sure how much common in Bombay, but I am getting frequent with the celiac now. And in celiac, one of the presentation is hyposplenism. Their spleen is working at low level compared to normal. That is hyposplenism. And that hyposplenism will give rise to the increased platelets, thrombocytosis. This is the thing that how malabsorption syndrome and platelets are high. How? That means hyposplenism. How the hyposplenism? Celiac. And therefore I will go for the endoscopy, biopsy and confirm, and we can treat it. So I think this is how we are getting the various clues from the simple investigations, which indicates something else, which indicates probably the pathway for further workup. And I think this is very, very important. We'll have to be familiar with these graphs. Probably now with this autoanalyzer, with every patient we are getting it. but probably hardly we are looking at. Hardly we are trying to learn that how best we can interpret them. They say that even the platelets are low, but mean platelet volume look at. And that way from the histogram we can interpret. I know that I remember that I learnt initially from Bharat and Nitin from Mumbai that how we can interpret these histograms, almost probably 5, 7 years, 10 years back. And now I can have the various ideas that how we should. So I think it is very important. So probably you are the postgraduate. Tomorrow ask a teacher that the histogram is very important for all of us to learn. Probably you go to the pathologist, learn them. And I'm sure that once you learn it, and if you apply in your daily practice, lots of the informations you can derive. We go very commonly with the acute phase reactant. ESR, CRP, procalcitonin. What is the importance? If somebody asks me probably, I remember that Dr. Rajesh Chokhani from Mumbai, he says very frequently that I don't go for the ESR. And probably he's not wrong. Please don't give the undue importance to the ESR. It's a very non-specific. If at all it is probably, maybe some infection. But one point is there for the ESR. If it is more than hundreds, 150, 200, occasionally I have come across, maybe the Kawasaki, maybe the collagen, maybe the tuberculosis, maybe the sarcoidosis. And I think these are the conditions which I may suspect. I will suspect, later on we to go for confirmation. But these are the things that how we can derive the close. And micro ESR we know that we are utilizing in neural infections, but that also now the people are not giving much importance. Very widely done, very badly interpreted the CRP. Very badly. Very commonly I am asking my student, why it is got the C-reactive protein and not he-reactive protein? We say the C-reactive protein. How she reacts. And what the C? Basically we know that this is the protein derived from the liver. Whenever any stress, whenever any inflammation, whenever any trauma, this is very non-specific. And that protein goes in the circulation. But that protein, one test we have derived, that it reacts with the C polysaccharide of the streptococcal. And therefore we derive the C-reactive protein. That means protein reacting to C polysaccharide of the streptococcal. That's the thing that how the C-reactive protein name is derived. I think that we should know. Many times I like it that we should know the detailed history, everything. It is very important. Then we have not to then remember. Now, if you have the idea, probably we understand that what importance should be given. In urate also even more than 0.8 may be considered normal, but we know that initially first 4 days even may be abnormal. But birth asphyxia something, fever, sepsis suspected, CRP positive, sepsis, antibiotics. I think this is the equation what we apply. That's very dangerous. And that's why I am discussing very frequently. On the contrary, even just kyphelohematoma, just muconium aspiration can also give rise to the CRP. So that's very important, friends, and please don't give the undue importance. Already I talked the positive predictive value and negative predictive value that we should apply in our daily practice. Very important point that if suppose the febrile newborn, well-looking newborn comes to me, they are very difficult for us to say it is bacterial or non-bacterial fever. And here we know that the newborns, in a case of fever, maybe the bacteremia, is a life-threatening condition. Well-looking baby I am talking. And if I don't understand probably, after a few hours or the next day, baby may become the moribund or may even it may cause even the mortality. So it's a life-threatening situation. Here probably we are very keen for investigations and management. I think that you know that I will not go into the details, but less than 3 months febrile baby is very, I will say, it requires more attention. Now here suppose if I go for the newborn, CRP, first CRP may be negative because it takes some time. And therefore always go for the second CRP after 12 hours, 12 to 24 hours. Suppose second CRP is also negative, probably it increases my confidence that infection is less likely. I think this is the importance of the CRP. On the contrary, when CRP is positive in a case of sepsis and now we are giving the antibiotics and serial CRP is decreasing, probably it gives us a clue that your antibiotics are working. And even the fever is also there, that still probably does not require the change of antibiotics. Fever may be due to something else. So I think that's the thing how we can apply. And we know that within few days, CRP comes to normal. But really if the patient is improving, but still the CRP remains persistently high or increasing, probably it indicates some complication. That complication is suppose in a case of bacterial meningitis, maybe in that situation, maybe the abscess, brain abscess, maybe even some subdural collection, that can also be the possible complication. Or even the osteomyelitis, not uncommon in the newborns. On the contrary, any baby with a history of hospitalization in NICU, discharge and coming back with the decreased movement of any limb, keep in mind the first osteomyelitis, not uncommon. And at the same time, even the septic arthritis, NEC. So these are the situations which we should keep in mind. Very important point which I want to bring to your notice that a CRP estimation in CSF is no value. We have done the several dissertations in the past. But at present probably in the CSF, CRP has no value. On the contrary, CRP is a marker of non-infectious inflammatory disorder we should keep in mind. Kawasaki more than 200. Any case of fever of more than 5 days, when I don't have the answer, and that child develops even the skin lesions, with that even the leukocytosis and CRP ESR more than 100, and we know that Kawasaki is in the clinical diagnosis. Why I am afraid? If I am late, probably may cause the coronary damage. And therefore, as a clinician, we should be very competent enough to diagnose it and to manage it appropriately. We'll have to keep the balance. Overdiagnosis is also not desirable. And we should not miss it also. At the same time, we know the autoimmune disease, pancreatitis, even Crohn's disease. I am learning from the one madam from South, I don't remember her name, but she said that the Crohn's disease is not uncommon in India. She showed even several 5-7 cases which she came across. So probably we are not aware of it, and that we should keep in mind. We know that the graft versus host disease and allograft rejection are also, we are learning from our friends, those who are working in immunology and particularly even the hematology. Procalcitonin. Probably procalcitonin came and disappeared also. I think it's a good thing. In short, don't give them much importance. Okay, probably before, if you learn the whole inflammatory process in the body, with the inflammation for the cytokines comes in the picture, then the procalcitonin, then the CRP, then the WBC, then the monocytes and other cells. And therefore probably the whole series will give the idea that what the stage of inflammation. So probably procalcitonin can be used to catch the infection earliest. But somehow practical utility we didn't get it, and probably we may not give it much importance. I think malaria parasitological diagnosis is very important. Probably for the pediatrician of this country should be master of some 7 to 8 diseases. And I'm sure that your 80% practices would be well. And one of them is the malaria. Very important that what we used to say from the radio, that any patient with a fever, give the chloroquine. On the postcard we used to write down that a chloroquine. And we know that it has created the problem of multi-drug resistance malaria. Now on the contrary, before starting the antimalarials, we should have sufficient background to start it. Don't start randomly. Very important. And for that, macroscopic and the rapid diagnostic tests are very important. We should know the limitations also. On the contrary, till today even, macroscopic examination is the gold standard. Every probably student should be aware of it, how to prepare the thick and thin smear. Many times in the round I tell the student that you prepare the smear, I would like to say. And that probably we'll have to do. Thick smear will give the presence of the parasites. Thin smear will help you to identify the parasite species, whether it is really falciparum or the P. vivax. And that is very important. The only point, whenever you are suspecting, go for the repeated smear examination. That's the only main answer. One smear negative does not exclude it. You have to go for repeated smear examination. Smear should be prepared appropriately. Even from the EDTA blood, if you prepare within 2 hours, it is useful. Many times probably on the next day, we ask, sample बचा है? हाँ है तो उसमें से smear कर दो. मेरे ख्याल से उसमें कुछ नहीं मिलेगा. On the contrary, that will misguide you. That is not to be done. Minimum 100 fields should be examined. And therefore, probably another thing I have learnt while working in the field, that lack of knowledge is less responsible for the complications. But lack of sincerity is the biggest problem at all the levels. Probably it's not so that a person does not know undescended testes. But he has not examined the testes, and therefore undescended testes is missed. And that's lack of sincerity probably is not pardonable. If I do it, still my interpretation is wrong, probably everybody will have to pardon me. But not doing at all is never pardonable. And I think that is the biggest problem. And I do not wish. On the contrary, whenever I get the opportunity to address a postgraduate, I really, to be very frank, I am most happy. Because I know that if I do something, and some of you even remember these things, it is going to pay a lot in the future. That's true. So probably never even go for the insincerity. Even tell your teacher even that I will not be able to do. I'll be happy to learn. But once you accept it and don't do it, is the greatest blunder. And in the future, in short, never do it. This is very important. 100 smears, who is going to examine? And therefore probably we don't get it. Many people say that we are not getting it because we are not examining. Because we'll have to see the 50 smears in a day. We'll have to see 200 patients in a day. I don't know in the 200 patients what we are going to see. So first you decide that what you want to do. And then the interpretation and everything is going to be right. So this is even from the peripheral smear, if I'm getting the falciparum malaria. But in one patient, suppose if there are trophocytes, in another patient schizont, it also makes difference to me. Schizont is the early stage of the malarial parasite, falciparum malaria. It gives me some time for the management. If I manage in time, probably further patient will not go for the complication. If I give the most effective artesunate, patient will not go for further complications. But trophocytes is the mature form. It is having more of the cytoadherence property. And if I am late, probably it will go further, land up with the complications. And therefore I will be in hurry to give the artesunate first dose in a patient of trophocyte. Probably schizont, if I am little bit late, okay. But trophocyte, I will insist my resident that in the round just now you give the first dose. I think that's the difference in the interpretation. Schizont and trophocytes, that also makes difference in my understanding. And I think that's very important. Even parasite density is very important. Good pathology just say that even the malarial pigments in the polymorphs, even in absence of, I will say, parasites, good evidence to say it is a malaria. We know. Because that the secret is formed, we will not be able to get it. Mixed infection, many times it becomes very difficult. Rapid diagnostic test, in the details, I may not go much details to save the time, but in the emergency when the smear examination is not possible, go for the rapid diagnostic test for the interpretation. But a very important point, you should know the limitations of this test, which already I discussed, HRP2, which will remain positive for the long time. And probably LDH becomes negative within few days. But that is very important that we should know the limitation of the test also. Enteric fever. CBC probably already I discussed. Hemoglobin may be normal. Unless it really there is drop of hemoglobin, maybe the chronic infection or even the GI tract loss. And the GI tract loss is very easily missed by any person. And therefore 3 consecutive stool examination for occult blood is very important. Whenever you are suspecting loss of the blood from the GI tract, go for this test, quite rewarding. Maybe I will say simple due to aspirin which I am giving in a case of Kawasaki. In a case of Kawasaki, I am giving the aspirin for the long time. The patient comes with the anemia later on. And I don't have the answer for the anemia. Go for the stool examination. And I am sure that you will get that the aspirin is responsible for this macroscopic blood loss from the GI tract, responsible for the anemia. These points are rewarding a lot. In a case of enteric, don't expect always the leukopenia. Leukopenia will be in only 20-25% cases. Maybe even the leukocytosis. Therefore, leukocytosis does not exclude even the enteric. Very important point is eosinopenia, which already I talked, which is found in 70-80% of the patients. So CBC probably how best we can interpret in enteric. And platelets count. But platelets count will be low after the first week. In malaria, immediately. Dengue later on. So at what time I am getting a thrombocytopenia is also very, very important for interpreting it properly. I think if you remember only one sentence, I will be most happy for the enteric. Go for the blood culture. Never treat any patient, I will say, in a suspected case of enteric before collection of the blood for the culture. To be very frank, I have also learnt in the last few years. It was not routine in my practice. But I learned that it is rewarding like anything. Last year only we have analyzed the enteric cases in our medical college. I don't remember, probably out of 140 or so, 80 patients blood culture positive, Salmonella typhi culture positive. And out of them probably 10 to 15 patients paratyphi. That means I am learning that paratyphi is also coming up because we are giving the vaccine which is not protecting to the paratyphi. Lots many things we are learning, provided we do it properly. So I think that's very important. Collective, and Salmonella is very easy to culture, to grow. And therefore probably we should go for that. Culture is very important. Appropriate technique is very important. Everything In a case of fever, suppose of long duration, and if you are doing the bone marrow, maybe you are keeping in mind some malignancy. But every patient is not as per our clinical diagnosis. Maybe even something different also. And I have learned from my friend hematologist that in this situation always send the bone marrow for the culture. You may get even, may not be malignancy but something else. I remember this patient I have discussed several places, even in Mumbai also, with the MB once, that the patient from the Udaipur came to me for the fever after 3-4 months. Hospital at various places, every treatment was given. You understand in 3 months everything patient is going to get it. In this patient I was also not sure. Fever was going on. Count was low. Platelets little bit low. So I was thinking for the malignancy. Actually before that somebody did the bone marrow at some other place, keeping in mind this malignancy, because fever was going on since long. Here I also asked for the malignancy. I said that first time when sometimes bone marrow may not show. Now we don't have the answer, so let us go for the second bone marrow. My hematologist asked me that it is routine in my practice, therefore I have sent for the culture. To be very frank, I learned from my hematologist from that day. I said, I am suspecting of malignancy. He said, malignancy is not there, forget it. Okay. I was not sure that maybe then tuberculosis or something. But after 5 days, I got that bone marrow is showing the Salmonella typhi. That was the resistant case of the enteric which I learned. But even the blood culture was done in that patient, which was not showing but the bone marrow showed the culture of this Salmonella typhi. This is an important layer. And therefore, any patient of fever of unknown origin, if you go for the bone marrow is one of the investigations in PO, always go for the culture of this marrow. This is very important message. And that is probably, that it is an intracellular organism. Initially, you will get the culture positive blood because the Salmonella typhi in the circulation. If I tell the figure, the median bacterium in the bone marrow is 9 colony forming unit per ml compared to 0.3 in the blood. But the bone marrow peripheral blood ratio, which is around 4.8 in the first week, goes more than 100 times later on. That means, Salmonella typhi parasites, they are initially in the circulation. As the time passes, RE system organ they take away. In RE system organs, that means spleen, lymph node, bone marrow. And therefore now these parasites are gathered, shelter, they have got the shelter in these RE system organs. And therefore you are late whenever you are suspecting the enteric, go for the bone marrow, send the culture. And this every textbook mentions. And then I translate in the practice also. It is quite rewarding. So I think this is important lesson, that whenever you go for the bone marrow, send for the culture. And on the contrary, you are suspecting entry given, bone marrow may help us. Probably this clot and everything is now not important. Stool and urine, probably the cultures we do discuss for probably from the practice point of view, not much utility. Vidal, very difficult. You know, the antibodies against the O antigen are initially IgM type, and therefore first titer will be O will be positive, but will disappear also early. H titer will appear late, it will persist for long time. And therefore, you know, when the borderline OA and H titer, I think we should go for the comparison. That O is lower side, but H is higher, likely that it is a positive. When I think obviously 360, 480, there is no point of discussion. But when both are borderline titer, and if you go for the repeat titer, probably that will help a lot. So I think this point is very important, and you know, it's our daily problem in a case of hand-trick. Second thing, you know that this test should be performed at the very appropriate time. That is very important. We should remember that whatever the test we are performing is having the poor sensitivity, particularly if it is done early or somebody has given the antibiotics. At the same time, we know that it is not even specific test also. That means without the hand-trick also it can be positive due to the endemicity and anamnestic reasons. So we'll have to keep in mind everything before we interpret it. Just Vidal, not necessarily hand-trick. Very important that send after 1 week, and even you may go for repeat Vidal and rising titer probably, that will increase our confidence. Very important, somebody has very nicely mentioned that use intelligently the Vidal test. That means in intelligence we will have to go for interpretation of all these points. Slide test, never perform it. Or I will say somebody has performed, don't look at it. I want to emphasize this much, because probably hardly is helping, most of the time misguiding. Ask your pathologist, I want serum Vidal by titer method next day by the very appropriate titer. I think that is very important. We should know that even Vidal has different laboratories showing the different readings. That may be even due to the variations, due to the various kits and purity of the antigens which they are using. So I think that is also the technical problem. So when we are interpreting, you know, many of the patient is asking us, सर वो लेबोरेटरी में पॉजिटिव आया, यहाँ पे नेगेटिव है, वहाँ पे तो थोड़ा सा टाइटर था, अभी यहाँ से ज्यादा है, बट बोथ देख के भी आप तो बोलते हैं कि विडाल एंट्रिक तो है ही नहीं. Then I think we should be able to explain that what's the problem or why we are interpreting in this way. We should know that this typhoid vaccine which we are giving, that is the VI polysaccharide, which will not interfere with your Vidal report or antibody titer. I think that is a very important point which we can keep in mind. Dengue. Dengue should be diagnosed clinically. No test. Remember only one sentence, I think, very important. Laboratory investigations will help you probably for circumstantial evidences to derive the diagnosis, but it's not the final answer. On the contrary, serial, CBC and hematocrit will help me for further monitoring the patient, whether the patient is responding, deteriorating, developing some complication. Probably that will be the great help from the repeat these serial investigations. Serological tests probably will not help me for the management of the patient. Probably from the epidemiological data, yes, that how many patients of the dengue are there in the particular season in the Mumbai. And probably from that you can derive the various steps. That is for the preventive science probably. But particularly for the individual patient management, serological test has not much value. Very important point regarding the CBC, which probably I touched it in the initial phase also. That hemoglobin is low, normal, count is low, eosinopenia, and platelets low in the later phase, maybe in the entry. Drop of hemoglobin, drop of platelets probably very common with the malaria. On the contrary, hemoglobin is rising. That's the point indicating hemoconcentration. And low count and low platelets. Probably that may help us to derive the dengue. Or any other viral also, the same problem. So I think the CBC should be interpreted with this and put the picture. That will give you some idea. And whenever you are looking at the patient of some infection where you are not sure, but if you have seen these are the picture, that fever was there, but now fever is coming down. Patient is improving from the fever point of view. Hematocrit is increasing, hemoglobin or hematocrit is increasing. Platelets and WBC is going down. I think from this simple interpretation, we can say it's a dengue. And if I don't understand, later on go for the drop of blood pressure and patient will go for the shock. So I think before going for all the things, from the serial investigations, I think we should be able to interpret it very appropriately. Serological test, usually we don't go, but if you go after the 5 days. Now on the contrary, Dr. Tanu Singhal very nicely insists that go for the NS1 and serological test together. Probably that will help us a lot. I will tell you that how it helps. This is very important that whenever you are getting the IgG and IgM, how best we can draw the conclusion. Probably both are negative. Okay, may not be dengue, or probably we are early for the test. IgM is negative, IgG is positive, but low titer probably indicates some past infection. And I should not worry for the present problem. IgM is negative, IgG is positive but very high, that means secondary dengue, and may go for the immunological problem. We know, and that patient may deteriorate. IgM is positive, G negative, probably primary dengue. IgM is positive, IgG is positive but low, that means current respiratory infection or maybe the dengue fever. Very important point that IgM is positive. In short, IgG is very high. On the contrary, you should ask your friend pathologist or microbiologist that you use the kit where the IgG high titer can also be detected. Probably they are not able to do it. If the high titer of IgG is detected, very definitely indicates secondary dengue infection. And we know that secondary dengue infection will give rise to the more of immunological problems and more of the severe dengue fever and its complications. So I think that's the thing that how we can go for the interpretation. NS1 again, it is the very first, it's a non-structural antigen 1 that you know NS1. It is positive in the early phase which may remain for the up to the 9 days. But the very important point that it is at the cross-reactivity, everything we should keep in mind. UTI point of view, mild proteinuria may be there. If it is centrifuge sample and more than 5 leukocytes is there, or uncentrifuged and more than 10 leukocytes, I will give the importance. In any case of fever, 3 or 4 per cells, don't give the importance, or RBC. That can be when it is a febrile condition, which should not be misinterpreted for the UTI. And bacteria or gram stain is very important. Now, these rapid tests are particularly for this emergency where the probably urine examination may not be possible, and as that strip is available, we should now start to use it routinely. It is quite rewarding. Very important is the interpretation of urine culture. Suprapubic, which usually we don't do, but due to some dissertation or some medical college if you have done, and even showing the single organism is positive. That's the, I will say, utility of the suprapubic. Commonly we go for the midstream, and midstream should be, colony count should be more than 10⁵. This is very important point which we should keep in mind. But very important that every time it may not be 10⁵. Young infants, they pass urine frequently and therefore may not be the high colony count. In their situation, infants when more than 10⁴, you may give the importance. Or adolescents where probably cystitis even 10⁵ or 10⁴ even. And if the lower colony count may be found the patients, those who already are getting the antibiotics by somebody or already you are giving the prophylaxis. So in the short, the colony count should be interpreted appropriately with the age of the child, treatment receiving, and how, by which method you have collected the urine sample. Mento test. Ideally, one should use the 1-TU PPD RT23 twin 80. I always ask to explain everything. What is RT23? Anybody? What is RT23? RT23 is a preservative. Twin 80 is a detergent, so that it does not allow the tuberculin protein to adhere with the glass syringe, and that is to be used. Second thing, PPD should be preserved in the refrigerator. We should not keep it outdoor only. And therefore always I ask, therefore we say that we are not getting the mentotase positive, how you are going to get it? The PPD should be kept in the, where you are keeping the DPT vaccine. That is to 8 degrees centigrade. It is very important. We should use only 1 TU. At the most 2 TU or 5 TU, but never the 10 TU. If you are using the 10 TU and getting the mentotase positive is not having the importance. I think this is very, very important. And interpretation, as of you know, that 48 to 72 hours. Transverse diameter is very important because it corresponds to the lymphatics. And even but the patient is supposed coming late to me after 5 days, 6 days, but it will be positive, probably I may consider the positive, even up to the 7 days. I think this is very important practical point. And more than 10 millimeter in healthy children, immunologically competent, but in HIV, the cutoff value is more than 5 millimeter, should be considered positive. Very important that prior BCG is not interfering the mentotest. I think we don't have the much case for the tuberculosis, but these are very important points. BCG should never be used for that purpose. Probably demonstration of AFB is very important. On the contrary, at present I insist so much to my residents or even these subordinates that unless I get the AFB, I am not going to start the AKT. And if you want really to convince me, even bring the AFB of some other patient. But show me the AFB probably then and then I will start the AKT. Why I am insisting so much? We know that MDR, extended MDR, all these issues are man-made. Probably we should not, we cannot. If I don't start the AKT probably in this patient really suffering from tuberculosis, if I am not able to decide, somebody else starts later on after I think, probably it's not wrong. There is no hurry, because he is not going to kill the patient. But the MDR or no drug is working is going to kill not only one patient, multiple patients. And I think as a clinician, we should be very clear. You know, we are working as a scientist. We cannot just, I will say, give whatever we want to wish. We should have the appropriate interpretation. And nowadays, please don't say that in the pediatric patients, difficult to get the AFB. Always I ask, in how many patients have you tried? Probably we have not tried. You know, the world literature, I am learning from Dr. Varinder Singh and all the people, those who are working, that 33% in our primary disease even, children, if they are getting, why should not I get it? The reason is probably we are not doing properly. So we have to do it. Every attempt should be done, as I said, to get this bacteriologically diagnosis. Younger child go for the, I will say, gastric aspirate. And now the gastric aspirate, not necessarily child should be hospitalized and next day morning I should get the sample. 6 hour fasting is sufficient, as outdoor you can. But even go for the saline or addition of doing or something, but get this sample. Today I am not going to speak on the tuberculosis, but sometime I will speak you. The cases I will show you where we have got the AFB in this way, and my confidence has increased. That beyond that we cannot do. Probably we are not permitted. If I am not able to help, okay, this is my limitation. But I am not allowed to do something wrong, which is more dangerous. I think as a clinician we should learn it. Sputum can be induced by 3% even nebulized hypertonic saline. Probably now our friends, they are doing frequently in the bronchoscopy where we are probably don't have the diagnosis. Get the ball. Now every patient of the bronchoscopy, for foreign body even suppose I have submitted, I tell my friend that please get the ball. I would like to send for the examination. I know that cystic fibrosis I learned from this technique only. That for what reason I was doing, I think I can quote even Madam Udani, Sonu Udani, one of the patients, what she did the bronchoscopy in Hinduja. She described very nicely that rope-like structure, material she was able to see in the bronchoscopy. Later on it turned out to be pseudomonas and the cystic fibrosis. So what I mean to say that we are learning lot many things if we have done it properly, if we have interpreted it properly. We should be aware of it. And for this, even this gastric aspirate, we used to say 3 samples, but now they said even the 2 samples will do. I say at least 2 samples, but do at least. That's very important. And as I said, bronchoscopy, anything if you are, even one thing I insist that any material you have got, either from the bronchoscopy or the gastric aspirate, or fine needle aspiration cytology, or ascitic fluid, or pleural fluid, anything, send for the culture. Send for the Zn stain. And I'm sure that if you perform this habit regularly, frequently you are getting the evidences of tuberculosis. I'm sure that once you start it, you are going to get it. And this is very important. And you know that now the microbiological technique has improved a lot. I know that one of the patients which I was referred for the considering multiple drug-resistant tuberculosis. But when I saw the patient is improving, no fever, gaining the weight, okay, that X-ray chest was showing the enlarged lymph node, which was still increasing in the size. And the paradoxical phenomena can occur. But we went for this examination, we got even the AFB, and we gone for the line probe, that is the gene expert interpretation, which showed that both the drugs are working as rifampicin. I showed this pediatrician that is not question of MDR. And you know, by proving it, we are also able to treat the patient confidently. We can say even this that there is no MDR. In the due course of time, patient improved. If I wrongly interpret even the MDR, it is also the blunder. So I think this is very, very important. And once we go probably for this exercise, I'm damn sure that we are going to get it. And therefore, you know, this MGIT system is everywhere now. In most of the medical colleges, it will be there. That is mycobacterial growth indicator tube. And by that method, you must be knowing that within the short time, even the report is available. Gene expert, you know that within 60 to 90 minutes, he can tell us whether the ionized rifampicin are going to work or not. That technology is already existent. We'll have to learn how best we can utilize it. And we'll have to learn how best we can go for the interpretation of this technique. Friends, I think you must have forgotten now serological test. And if you have not forgotten, forget it forever. It is never recommended, and even to that extent that we are not following the science, so WHO has banned now. Never do any serological test. Whoever person has done, don't start the AKT on this basis. Very important message. And therefore I have devoted, I will say, 1 slide for this message. Another test has come, interferon gamma release assay. What is this? Basically, you know, Mycobacterium tuberculosis, by the effect of the monocytes, they are releasing one substance, protein, interferon gamma. And that interferon gamma, we are detecting. And then we are utilizing for the diagnosis of tuberculosis. It is just like the Mento test. It measures the production of the interferon gamma by the peripheral mononuclear cells. Basically, there is by the antigen target 6 and culture filtered protein. These are the 2 antigens, in short, responsible for this the interferon gamma. And they are the only thing that they are not by the effect of BCG. Therefore, probably we are very clear. Second thing, it is only by the Mycobacterium tuberculosis, not only any other mycobacteria, not atypical, not Mycobacterial apiary. So I think it gives the information that these are the merits or the validity of this test. But at the same time, what are the problems? We have the 2 tests available, quantiferon gold and the T-spots. 2 these kits are available and we are able to do. The only thing it does not help us as a Mento test. It's a really infection or disease. And I think that's a problem with the clinician. So not helping much. Actually, where this test is useful, in Western country, yes, or where the disease is having the low prevalence. But when the country like India, very high prevalence, and when I want to decide whether it is infection or disease, probably this test does not help. And the point is, don't jump unnecessarily for this test. Probably it is just like the Mento test. If it is asked in the MD examination, short note, write very nicely to get the good marks. But probably should not be translated in the practice. PCR okay, basically good test. very sophisticated. The only thing that false positive technique of the PCR having the limitations, and therefore probably not recommended routinely or practice. But suppose somebody does in a very specific situation, I will recommend and I will respect even. That definitely is a good test. If it is done very appropriately, it helps a lot. And if you have got it probably in very specific situation, definitely we can respect it. There is no substitute for lumbar puncture in CSF examination for meningitis. I remember long back one practitioner told me that if you diagnose or if you don't diagnose, if I give the 10 days antibiotics, what is wrong? I said, suppose patient recovers, nothing is wrong, even without meningitis also. But once the patient develops the complication, then every series of the complications starts now, not only the science point of view, even law point of view. Patient develops some problems or complications, I will say hydrocephalus, brain abscess. And we know that the newborn or the infant, due to lack of our, I will say, proper working, brain is damaged, and child becomes, I will say, handicapped for the lifetime, is the greatest crime. And I'm sure that now law also does not permit us. Therefore, any patient, even I was a suspected case of meningitis, in my round, in a light mood, I say that if the child is irritable, even the resident is lethargic or irritable, do the lumbar puncture. Probably there may be some problem. What I mean to say, I want to insist so much that probably for confirmation of meningitis, there is no any other test except the lumbar puncture. CT scan is not going to give you the diagnosis. CSF sugar, if it is not collected in the, therefore I started with the collection. If it is not in the fluoride bulb, unnecessarily it will give the low reading of the CSF sugar. And then we will say decrease due to the meningitis. Very important point for the cell count, as I said, CSF should be examined within 30 minutes. I think from tomorrow, make the alert our friends that cell count should be done within 30 minutes. You may give the chemistry later on. But otherwise the cell lysis and your cell count is going to be low. If you read open the Mankey, if you are interested in pediatric neurology, very nice, I like it very much. So distinctly he has mentioned that examination of CSF, not only during the lumbar puncture is important, examination is very important. Technique is very important. Interpretation is very important. And therefore, if you are not collecting the CSF in the fluoride bulb, probably your sugar interpretation is wrong. If CSF cell count is not done within 30 minutes, your count may be low. So I think these are the very, very important. Not only that CSF sugar, but ratio is very important. With the reference to blood sugar. And the blood sugar sample should be collected before doing the lumbar puncture. They say that lumbar puncture, that procedure itself, that trauma may increase the blood sugar level. And your interpretation may be wrong. इसमें तो सहदेव जैसा है, जितना जाने इतनी ज्यादा मुश्किल है. If you are knowing more, then more problems. But results are good. Problems are that, but results are good. And therefore, in the case of meningitis, first blood sugar, CSF, lumbar puncture, CSF sugar and the ratio. I think these are the very important points. Just appearance of the turbid cell. Very commonly the people will ask you in the MD examination, the Viva. Turbid CSF is due to what? People answer the protein. No. Actually, it is due to the cells more than 250 to 300. More than 300 cells indicates the turbid. Protein may be playing the role. I don't say totally wrong. But the main appearance of the turbid is due to, this is simply just looking at the CSF, you can say meningitis. And it will be right. Gram stain is very important. They say sensitivity is almost 40 to 70%. Latex agglutination tests are available for H. influenza, meningococcal, pneumococcal, and cost is only 2,500. So I think that we can do in a traumatic lumbar puncture. CSF culture is very important. As I told you, any material from probably now onwards should not be left without the culture. And I'm sure that it will be quite rewarding. This is very important. I think table is given the Nielsen. I skip it for saving the time. Traumatic CSF is very important. I think very common. And when the new batch comes of the residents, incidence of the traumatic lumbar puncture increases. When they become the severe, gradually comes down. And it happens, naturally, it is going to happen. Fairly common. How we can interpret? We know the RBC-WBC ratio. And this examination again within 30 minutes. You can see that the proportion of the RBC and the protein. 1 milligram% of the protein increases by 100 RBCs. So that you can go for the calculation. Sugar may be low. Gram scale. Culture will help you. Very important, if you are not able to decide, you repeat CSF after 48 hours. That's very, very important. That helps a lot. I think for neonatal sepsis, if I tell you only in the short, probably 3 parameters are very important. Total count, here it is mistake, less than 5,000, not 500. IT ratio and CRP. If any 2 are positive out of the 3, and clinically if I consider neonatal sepsis, probably most of the times we are right, justified. Lot many things we go for neonatal sepsis. Every probably point is having some or other problem, but probably if you put together the 3 parameters, that helps a lot. And that is given in most of the standard textbooks, and our NF is also accepted. Already I have discussed with you. Very important point. Probably gradually I am now coming to the end. Taken sufficient time to sensitize you. If somebody asks me, I think Ambedkar sir has this habit, very frequently he asks me, when you last you have asked for the stool examination? Routinely never. I think drop this habit. You know, sometimes we have the wrong habits also. As it is in our routine life, in our working also the wrong habits. Acute diarrheal disease, probably stool examination does not help us. Unless it is malabsorption syndrome, unless it is dysentery, unless it is a patient of HIV, unless really true diarrhea in a case of neonate. In that situation, stool examination will help me. But just I will say the patient who has come healthy and hearty, nutritionally good, immunologically competent, taken the food from outside, or really rotaviral problem, I think that situation, stool examination will, on the contrary, will misguide you. And many times the practice you will see. Presence of few WBC and RBC in the stool does not signify anything, friends. Even the viral infection, rotaviral infection, diarrhea, you may get few WBC or even the RBC. You may get 5, 7 RBC or WBC. Not necessarily that patient requires antibiotics. That's why I say, don't go for the stool examination. Karo to kuch milega nahi. Examination hi mat karo. There is no need. WHO has also given the guidelines. There is no need to go for the stool examination. On the contrary, it misguides by the few pus cells, few RBCs. And you know, these pathologists will go for the yellow coloration to highlight it. And the clinician will do the very good circle that there is a problem. And then he will write down the 2-3 antibiotics. I think we do not want to go for this practice. Interpretation ही करना नहीं है, stool examination नहीं करना है. I think this is very important. Presence of reduced substance, you know, mother will say कि वो दूध उसको पचता नहीं है, because reduced substance is there, and people will say lactose intolerance. We know that lactose is normal composition of the breast milk. Compared to other milks, you must be knowing that lactose is high. And nature has provided high lactose to give the good, I will say, calories to grow the child. And physiologically they have the lactase deficiency. And therefore I will say water is stool, maybe there normally. But once the child is developing very nicely, gaining the weight, no dehydration, why should I bother for this reduced substance in the stool? It's a normal phenomena. It does not require any treatment. And on the contrary, on this ground to stop the breast milk is again the crime. Probably there should be some provision in the Indian Penal Code to punish the person. To stop the breast milk on this basis. I know that several examples. Breast milk stopped by the medical person, pediatrician, for this reason. I think we should not be the party of it tomorrow. We know that breast milk probably may not having some limitations, but does not cause the harm. That is very certain. Maybe containing probably vitamin K low. Maybe there is some problem of calcium phosphorus ratio. Having some limitations, but no harm. And therefore probably in any circumstances, we are going to celebrate the first week of August. I think that should be a part of our celebration, that in any circumstances, breast milk should not be stopped, except mother is on the anti-thyroid drug, or really she has the postpartum psychosis and she may kill the child, or really she is on anti-malignant drugs, or really it's a case of galactosemia, and I don't have any other way. If somebody asks me probably in MD examination, why, these are the only situation where probably I am forced to stop the breast milk. How many patients do practice? Hardly. So in short, routinely probably it does not require. Reducing substance, karna hi nahi. Somebody has done, ignore it. Very important point which I want to highlight you. When I should say dysentery, and therefore frequently I ask my students in the round, define the dysentery. Few RBCs in the stool examination is not dysentery. Stool shows even the presence of blood by naked eye, which I can see, then definitely dysentery. And then probably question comes of antibiotics. If I hospitalize, ceftriaxone. If oral, cefixime. Probably no third one. This is also true. Very clear dictum. If somebody asks me that when you are using these, metronidazole for amoebic dysentery, I say that I am waiting for the amoebic dysentery. If I get it, I will treat it. Amoebic dysentery is less common in the pediatric practice. Maybe giardiasis may be the indication for the metronidazole, but probably not the amoebic dysentery. If really amoebic dysentery, when I will decide? If dysentery is there, I will go for the stool examination. And that stool examination shows trophocytes of Entamoeba histolytica. I said trophocytes, not the cyst. Trophocytes of the Entamoeba histolytica is a dysentery amoebic. Treat with a very specific drug. Or I consider the dysentery, sigilosis or something which I could not prove it. I have used a different two drugs, and both the drugs have failed. Then even in the absence of the evidence, I will say that maybe the amoebic, and I should treat it. And I think these are the very clear-cut indication given by the science, WHO, and our IAP also. And I think we should follow it very strictly. Definitely it will help you a lot in our daily practice. I think I have tried to take these very common conditions where we go for the laboratory investigations. Many times probably due to lack of our knowledge or time or due to certain reasons, we are not interpreting them properly. That I have tried to bring to your notice. I have highlighted these situations to sensitize you, so that probably I am expecting good antibody production, so that probably we'll have some protection. At some other time I will come as a booster, so that probably good long-term effect of this sensitization should be continued. What we should remember, what we learned. Please friends, remember this thing. Tomorrow onwards, before writing the clinical diagnosis, never go for the investigation. My clinical diagnosis may be wrong even. Tomorrow I will laugh at my diagnosis. Possible. इसमें ऐसा लिखा था, मैंने लिखा था, उसमें क्या ऐसा तो कुछ है नहीं. Okay, लिखा है. Whatever I felt it. But write it. So clinical diagnosis is very important from history and examination before investigation. Because you know, if you have the clinical diagnosis, you are planning your investigations based on it. Not randomly without any idea. If somebody asks you, why you have gone for the Vidal, you don't have the answer. On 4th day or 5th day, even in an entry, what is your idea? We are wasting the money. And suppose by chance some investigation comes positive, that misguides you. So don't go for unnecessary investigations. And therefore in our IPID chapter, we have prepared one module, rational investigation. Investigation will be rationality. That is very important. Second, collect the specimen before starting the drugs. When you are supposed right or wrong, if you are suspecting, collect the sample, because that will be quite rewarding. Aseptic precautions are very important. Probably that part is lacking with us. Contamination. And with contamination, our interpretation is wrong, line of treatment is wrong. Everything is wrong. So that is, I think, very, very important. You know that once the catheter is there, and from that catheter I collect the blood for the culture, I will get the colonized organisms. Cons even. So that's very important. Every point gives us a lots of rewards. Any procedure should be performed very appropriately. Procedure itself may be problematic. Collection of blood for the culture. Storage is very important, which already we have discussed. Timing is very important. Treatment, already what the patient has received, that will help you a lot. And one should be aware regarding the sensitivity and specificity, how much value of the test that we should know. And if the test has no value, probably on that we cannot base our diagnosis. Interpretation of any investigation, just don't go from the, I will say, figures or reading. What most of the Western country people are doing. Now they are repenting, gradually they are learning. I am also moving around the world and interacting with all these people and learning that they have also sensitized. 2 years back I was in Netherlands with some clinical case discussion, and when some 5-7 Indian pediatricians were sitting together, and how we know that lead for the discussion of the brucellosis, and what they were doing, even they also accepted that this is better method. Simply we sell brucellosis from our clinical things, and then how best we can go for the investigations. So I think this is a very important message. We will never interpret, I will say, investigations in the absence of the clinical picture. If there is no clinical picture is helping me to suspect that condition, that report is to be discarded. It is not useful to me. Very important message which we should keep in mind. Friends, we know that clinical diagnosis is must before the laboratory investigations. Please remember, investigations are neither shortcut. CT scan is not the shortcut. CT scan normal does not exclude the CNS problem. Right? What I want to emphasize, that there is no final answer for the diagnosis from the investigations. On the contrary, final answer can be given by the master clinician. Only from history, only from examination. Investigations will help me, it will guide me. But ultimately final conclusion can be drawn from all the correlation. And for that reason, what we keep the today's theme, that interpretation is very important, not just for the investigations. And I think with this, I thank you, all of you, for attending me, patient listening, and the good response. I think whatever you have, and never hesitate asking the question. Whatever the question you have. And I will never hesitate to answer you if I don't know. Yes, write down the questions, whatever you wish, whatever you have the query. Or you have some comment from this, you can, most welcome. Suppose if you differ or if you want to pass on some things. We have got even these questions from other friends who are attending at different places. You must be knowing that this is the webcast discussion, and so some of the friends are attending at different places also. They have also sent some of the questions. Let me, I think, till you come out with the questions, whatever the questions they have sent, I think we'll entertain. How to determine the colonizer versus the offenders? First we know that whatever the organism it is, many times that organism is known as a colonizer. You know, cons. Coagulase negative staphylococcus. Most commonly they are colonizer. Unless probably it is in an immunologically compromised situation. Or second, suppose already catheter or something is there, or shunt is there in the case of hydrocephalus. In the CSF if I am getting some organism. You know this colonization is known. And that colonization can go into circulation and can give rise to the culture positive. Second, we know that even suppose 2 times if I go for the culture and both times same organism, then probably I will have to consider that this is less responsible but offender. So starting from the clinical picture of the patient, to even the organism, to even the circumstances of the patient, and even the repeat reports of the culture, we can derive this conclusion. Are there any special precautions that needs to be taken to ensure the viability of the pathogens? I think very important point is number 1, collection. Second thing is the ratio of this, when you are taking the blood culture. You must be knowing that the 1:5 the ratio has to be there. That means 5 times more of this broth. Suppose if I want to go, that means 5 cc of the broth, 1 cc that culture media, and 5 cc of the blood should be taken. Why this ratio is to be maintained? Anybody knows? Sorry, I did the mistake. 5 cc should be taken the broth, 1 cc should be taken the blood. Why we go for this ratio? Anybody have any idea? I think this question we can answer very easily from that. If I go for some disproportionate, or why we go for the dilution? Or that's why what he has questioned, that needs some precaution for the good viability of the pathogen? Yes, and this is the good dilution. The reason is, our blood also contains defense components. Blood contains immunoglobulins, blood contains even the neutrophil, WBC and other cells. They can also kill the organism. We go for the dilution so that even all the defense components will get diluted. And their effect for the inhibition of the growth can be nullified or decreased. Therefore, this proportion of the dilution, that 5 times more broth should be taken. And that is one of the very important, step to see that the organism remains viable. Second thing, already we said the proper storage. Third, even the proper collection. So I think all the points will help us for the proper viability of the organism. How much time does it take for fungal to become the culture positive? I think fungal to become the positive, to be very frank, I don't know the exact time, but it takes weeks together. You may not get the culture positive in the 5 days time or 3 days time. So for fungal we'll have to wait. For brucellosis we'll have to wait for even weeks together, months together. And therefore whenever you are suspecting the brucellosis, that blood culture should be, you can request the microbiologist that culture sample should be continued for even the months together. I remember one patient, we got the blood culture brucellosis positive after 5 weeks. And so that it requires more time. So fungal, brucellosis, these are the organisms that require the more time. Can we differentiate between CA-MRSA and HA-MRSA on the basis of it? I think this is mainly, one is the MRSA will be the interpretation of microbiologist. Now the source of MRSA, microbiologist cannot answer. That will have to say that what is the source of infection. Suppose patient has come, I will say from community, it is community acquired. But the patient was hospitalized, I will say kept in the NICU or PICU, kept on ventilator or some, I will say, indwelling catheters. And now that patient has the, I will say, MRSA. We consider that these are hospital acquired. Point is very valid because both the situations require the very specific antibiotics. But microbiologically, they will say only MRSA. Source as a clinician from the circumstances we'll have to decide. Kindly comment on advances in tuberculosis diagnosis like, I think for the diagnosis tuberculosis, already I said many advancement has taken place. Starting from, I will say, number 1, even from the culture. MGIT is very good, besides the bactec. And for even the sensitivity, the gene expert is also very good. Within a very short time, you can get even the sensitivity test also. May not be probably required in all the patients. And very important even for growth, gastric aspirate. Even suppose if you have the mediastinal lymph node, even CT scan guided go for the biopsy. And now you must be knowing the Mumbai, at most of the places also, very good, I will say technically, efficiently radiologists they are doing. In short, go for the proper technique, go for this collection sample, and go for this culture or even the germ stain. How easily is the test to detect the biomarkers like CRP? Already probably we have discussed regarding the CRP, the same. CRP test easily available and what is the cost? I think that is the main thing. Easily availability is the biggest problem. And very cheap is adding to it. That's why probably frequently we go it. Probably hardly it, I will say, differs from center to center, but around 150 to 200 rupees, not more than that. Pardon me? Sensitivity to? I think I told that if you go for early phase, procalcitonin it will help. That is within few hours of a fever. But later on, if you go probably procalcitonin may be wrong, may be negative, and CRP will come positive. But some of the studies are there that in between the time, if you go for both, even procalcitonin or CRP, on the that combination is more reliable rather than the single test. Yeah. I said that already we discussed procalcitonin negative, that will be in the only acute phase. CRP, but already you said the patient is improving, so forget it, it will take time to come down. Or maybe having some complications from the simple thrombophlebitis. Just I will say thrombophlebitis. That can also give rise to the CRP. Patient is improving, afebrile, doing well, neglect the CRP. Will not treat the CRP, will treat the patient. I think typhi.m test already we have discussed. Are there any specific tests for paratyphi? I think for paratyphi culture positive, their paratyphi is very important. And even now we don't do, but even the Vidal test can be done for paratyphi titer also. Not only it is that ONH, their paratyphi titer can also be done. And very importantly the culture. I think that will help us. And that's why I told that even we are getting culture positive paratyphi. And does MEN2 help in differentiating infection from the already we discussed? Positive MEN2 test indicates this person is sensitized to this acid fast bacilli. Not necessarily disease. From other symptoms, from other evidences, you will have to decide whether it is really infection or disease. Is it right to repeat the MEN2 test? Oh, that's a good question. You know, we'll continue to repeat the MEN2 test till it comes positive. Because we are interested for the MEN2 test. Once I will say it's done with the proper PPD fluid, proper technique, negative means negative. Don't go for the repeated test. Unless if you have the doubt that it was subcutaneous, not done properly, okay, probably in that situation you may go for the repeat. But for the sake of till it comes positive, not necessary to continue to go for the repeat test. Most of the times probably we are doing for that purpose. Significance of bacteria and E. coli in the blood culture. Yes. Probably E. coli most of the times may be the contamination unless immunological compromise. And very common, that source may be the laboratory. And anaerobic, really if it is done properly the culture, then may not be the contamination. Most commonly that we are going to get with the intra-abdominal infections. Suppose some surgical complications after the abdominal surgery, or even perforation, or peritonitis, probably, or even in newborn NEC, we may get this anaerobic. And probably then we'll have to give the respect, that we cannot ignore it. But otherwise, I think other circumstances we may not give the much importance. Vidal report positive for 1:160 for H antigen without fever. Need to be treated. What you want to treat? Titer. And how will we be able to treat the titer? Nothing is to be done. Already I said it, that indicates that the person is exposed to Salmonella typhi and most commonly food from outside. And now there is no need to ask the history of food from outside, because all the 6-7 days history is positive for food from outside. Now we'll have to ask when you have taken the food from home. Probably that becomes easy. So I think that we know that there's a reason for this Vidal positive. Investigations name reducing substance tool significant, already we discussed, no significant, unless really it's a lactose intolerance. Again, for the lactose intolerance, I will rely more upon my clinical picture rather than the stool examination. Very rare, I will say. Somebody asked me, it's not common. Wrongly, we are treating many a times any diarrhea which continue for a long time. But it can be occasionally. How the patient comes. Lactose intolerance, we know that because lactose is not digested. It is actually disaccharide, which gets fermented, and therefore gaseous distension is very common. Lactose, we know that it is actually, again, it draws more of the osmotic diarrhea, so more fluid. And single even diarrhea will cause more fluid loss. So watery diarrhea, large quantity, distension of abdomen. Second thing, we know that it is converting in the ammonia and therefore even the perineal excoriation. And that situation is there, with that even the reduces substance probably, I may give the importance. But that comes very rare, and that is the persistent diarrhea we say. That is started with the acute, which continue for the more than 2 weeks. That is the persistent diarrhea. In the persistent diarrhea, probably lactose intolerance may be the one of the regions. That's right. But otherwise, in our routine practice, there is no problem. Diagnostic type for Vidal, at present we consider 1 to 160. Beyond that, we'll have to consider it. Diagnosis of role of Vidal, we have discussed sufficiently. Yes, sir, no role. Probably I am not sure whether a person was attending or absence of mind or sleeping. We'll have to go for differential diagnosis. Importance of, he has not mentioned. Patient with cough, 10 days. Mental test not significantly positive. Vaccine, BCG not given. X-ray test positive. AFB negative. Do you want to start the AKT? Very common story. The point is, we'll have to decide on which ground I will be able to say tuberculosis. I may suspect it, but I am not able to prove it. Number one, if the patient is in the chronic symptoms, even WHO says more than 2 weeks cough, you may give the possibility of tuberculosis, possibility. Don't start the AKT. You may investigate, you may give the antibiotics on the contrary for 10 days. Still suppose persist, you may go for further workup. And here you know what he has mentioned, Mento test is negative, X-ray test is positive, positive by what? Just Tyler, right, what we interpret is most of the times is the pulmonary blood vessel, normally anatomically it is present. On the left side hilar shadow, I may give some importance. Or on the contrary, if anything, as I said, you reach to that lymph node, take the biopsy. If you have the really very doubtful, strongly you are suspecting tuberculosis, you waited sufficiently, still if you don't have the answer. But without that, just I will say Mento test positive, just X-ray showing right hilar, cough, on that ground we cannot start the AKT. Very certainly we cannot. By chance if it is tuberculosis at present I am not able to diagnose, I will wait. In the due course of time, on follow-up, symptoms persist, there is weight loss, something new development, I will go for the gastric aspirate for 3 days even. And some evidence, or even some open case of tuberculosis, something. But I think only on this ground we cannot start the AKT. Please friends consider that days have gone. What we used to say, my experience, what I say, we'll have to show. Probably when what I am speaking, if somebody is opening the Nielsen and showing me, I will be most happy person. I am not allowed to speak anything, whatever I don't know. So I think it's true that whatever we are not able to diagnose, we cannot start the AKT. And we have started the AKT, therefore it is resulted in the MDR. When to repeat the CRP in the neurate after, usually you know after starting the antibiotics, if the patient is responding well, on the repeat probably CBC or something, you can go, and if it is declining, that means patient responding to your line of the treatment. Sending the clotting factors to distant place with courier, then what is the ideal method to send? That means he wants to go for the investigations for some bleeding coagulation disorder. And there is no facility. Already I said that we will have to collect the blood for the coagulation factors in citrate blood. And from citrate blood, usually those factors are not getting disturbed earlier. So probably in the very short time, if you are able to send this sample, it is not going to be disturbed or destructed. And there is no need to send even for this maintaining the temperature and everything. It is not required for the clotting factors. What is the cause of leukocytosis? 30,000, 40,000. Maybe the two things. Maybe the leukemia reaction. Pertussis, tuberculosis, or even any virulent organism can also do. Very bad sepsis can also do. The only thing that gives me the idea that with very bad infection, count is high. That means bone marrow is working very well. That means person is immunologically competent. That means I am expecting that with my antibiotics outcome should be good. I think that's the only thing which I can give. Very high count, not necessary I should go for change of antibiotics. That count should be brought down by giving some antibiotics. I think many times the people are asking for that. Sir, count तो बहुत high है तो change करेंगे क्यों? I think good, very high good count with stable patient. Probably it indicates that the body is working very well. Immunologically competent person. On the contrary, able to fight with your infection. It's a good thing. So on the contrary, I will continue the antibiotics. It's not the point for the, maybe even some other condition, tuberculosis, pertussis, that we can keep in mind. Sometimes it is seen the neonates on antibiotic. Now he is coming up. So I think it's a seen, commonly seen. Specifically broad spectrum with increased CRP and sometimes almost normalizes within few days automatically without the antibiotic. He is coming there in the same thing. Properly if you are treating, the due course of time patient improves, in short. Why thrombocytopenia and leukocytosis are seen in enteric fever? He has asked some, I think, medical student for explanation. Why the thrombocytopenia and leukocytosis are seen in enteric fever? You must be knowing, I think I have forgotten, but one toxin is there with the salmonella, which acts selectively on the bone marrow, on the progenitor cells for the leukocytes. And that is responsible for the leukopenia. I remember my teacher talking long back. The leukopenia, we were using the chloramphenicol for this enteric fever in those days. Chloramphenicol itself can cause this, even the bone marrow suppression is a problem. With a very low count, 2,000, 3,000, we'll say chloramphenicol should not be given. I remember my teacher that you give the chloramphenicol, count will improve. Because here the problem is not due to this chloramphenicol, but it is due to the enteric and the salmonella toxin, which is working on the leukocyte, I will say precursor cells. And if you treat them, it gets improved. So that's the reason specifically with the salmonella. And even peripherally also, thrombocytopenia may be due to destruction, due to toxin or something. It is not due to bone marrow. Or even both three series are affected. It can be the bone marrow suppression. That can be with the enteric toxin also. Can be due to some drugs also. So I think in that situation we'll have to consider that what factor is playing the role. How to interpret the hematocrit in dengue? How to decide the hemoconcentration? I think serial, one particular investigation may not help me. Because one person may be the hemoglobin of 12 gram. But that person even simultaneously goes for the leaking of the fluid in the form of the urine output is decreasing, feeling even the generalized weakness, that means some perfusion problem, and hemoglobin is increasing hematocrit. I think that all the together, that indicates that these are dengue and probably leaking. So I think that we can decide. And serial hematocrit, suppose increasing, probably that is patient is deteriorating. Leaking is more. Or really if the patient is deteriorating and still hemoglobin is even decreasing, rather than on the contrary the dengue you know that the patient is deteriorating, hemoglobin should be increasing because more hemoconcentration. But hemoglobin is decreasing or drop, that is bleeding in a case of dengue. This is very important marker. In a case of dengue, when the patient is not improving and still his hemoglobin is coming down, that means it's a bleeding. Even if we are not be able to see but occult bleeding, and I think that we should be able to interpret it. What is the normal cell count in CSF? In newborns up to 15 even, they have given the normal. In older children probably up to 5. And particularly even the neutrophil, single neutrophil even, is more important. It indicates the pathology. Lymphocytes can be there. I think most of the things are given in the standard textbook. Stool culture, never. Examination is nahi to culture for what reason? And still you are going to get the E. coli. On the contrary, if really truly if you want to go for dysentery, and particularly the strain of the E. coli, that's a different exercise. That the very good microbiology laboratories people can do for, I will say, some academic work. For our routine practice, stool culture does not require, except few patients, as I said, HIV, or probably in that other situation, or immunologically really compromised situation. But routine practice, stool culture should not be done. We are wasting the money and then we say that money medicine के लिए नहीं है, कैसे होगा? What is the role of soya powder? All these powders are useless. Whatever the powder it is, I will. Blanket, I will say, covering statement, if I give it, may not be that right, but consider it. I say that truly, I think he has asked me the reference to lactose intolerance. Please friends, believe me, lactose intolerance of two types. Primary, secondary. Primary, that means from the beginning, the person is having the deficit in heredity. That is how much the population is there. In African countries, 15%. I have read it recently, therefore I don't even know all the figures also. In India, they say less common, less than 5%. If you have some relatives say that I don't take the milk preparations, and if I don't tolerate, I develop the distension of abdomen, or even some colicky pain, or diarrhea. If somebody is, I will say, complaining in this way repeatedly on taking the milk, that may be the, I will say, basically mild lactase intolerance. Even in adults, that's a different situation. But the primary lactose deficiency may be in the newborn, particularly the preterm babies, because they don't have the maturity of the lactase. You know, lactase enzyme is present at the tip of the villi. And tip of the villi is not mature in the preterm babies. So they have the physiological. But it does not require any treatment. Due course of time, that is the maturity of the enzyme, they recover. If really secondary lactose intolerance due to some reason, as I say, only that requires a treatment. But blanket covering all these, I will say, not many names, and sometimes I don't remember the name also. These powders are not required because I don't use it. And not there is need also. I think Dr. Madhumita can ask me to stop whenever she wants. Yeah, it's over and over. By system, yeah, that's the biggest problem with the teachers. They don't have the time. Anyway, I think last few questions. It is necessary to do the repeat lumbar puncture after the treatment. I think if you attended, it indicates that the person has not attended IAP program given by the pediatric infectious disease, PSPID, problem solving pediatric infectious disease. Very, very good question. You have done the lumbar puncture, diagnosed bacterial meningitis. Suppose if you have got it even confirmed, meningococcal, treat for 5 to 7 days. Streptococcal, 7 to 10 days. If you have got even the H influenza, 10 days to 2 weeks. If the antibiotics are working very well, the patient improves within 48 to 72 hours. Patient continues to improve, they say there is no need to repeat the lumbar puncture. But if the patient does not improve after 48 to 72 hours, and if there is no any suspected complication like subdural or some other, go for the repeat lumbar puncture and decide line of the treatment from that. When the patient is improving, doing very well, for confirmation, at the end there is no need to go for the lumbar puncture. But very important for the neonate. Even the patient is improving after 48-72 hours, do the lumbar puncture. Because what I am assessing the clinical improvement in an older child, that is not true for the neonate. Neonate may show the clinical improvement, but may not be they showing the CSF. And therefore they say that the neonate ideally, I'm not sure whether how much we are following ideally. गीता में सब लिखा है, लाइफ में फॉलो नहीं होते हैं, लेकिन आइडियली होना चाहिए. Like that here, after 40 to 72 hours, in the newborn repeat CSF is must. So this is the evidence indication for repeat CSF. And I think for few of the questions, out of probably so many questions we tried to entertain, but really there is an overwhelming response from the friends here and even from other places for putting the questions. Some of them we have tried to solve their queries, and probably some other time we'll take the opportunity to address you with this type of the academic functions. Thank you, friends, for attending in large quantity, for interacting with me, and I'm sure that so many friends must have attended at different parts of the country, and probably this is the benefit of this modern technology which we can probably utilize for our learning. I should not forget the CIPLA family for inviting all of us, and particularly for me, and giving this opportunity. Thank you. Thanks a lot to all of you. When at probably reaching to midnight and you are sitting over here, probably waiting for the dinner, but still even without dinner you have waited and attended in the large quantity. Not only just I will say, but very actively you have participated and interacted in that way. Thank you, friends. Thanks a lot.